Okay, next section deals with the vagina. The vagina is a canal. It leads to the cervix, and the mucosa of the vagina is lined by non-keratinizing squamous epithelium. So those are a few basic ideas that we have to have in mind before we can move forward in our discussion. The very first lesion that we want to talk about is adenosis. Now, you would think that this is exceedingly rare and it's not important, but this becomes very high yield for examination purposes because it ties into embryology. And so what I'd like to remind you is that when you think about the vaginal canal, let's pretend that I'm drawing the canal up here. When we think about this vaginal canal, it's important to remember that during development in fetal life, that this lower two-thirds here, the epithelium that lines that lower two-thirds of the vagina, actually is derived from something called the urogenital sinus. And so the lower two-thirds of the canal, its squamous epithelium, is derived from the urogenital sinus. And the upper one-third is actually derived from the Mullerian duct. And so it's not squamous, it's actually columnar. So again, the lower two-thirds is squamous in fetal life, and then the upper one-third is derived from the Mullerian duct, which is columnar. Now, what happens is that the squamous epithelium during development from this lower two-thirds actually replaces the columnar epithelium over the period of development, so that the entire vaginal canal in a normal female should be completely lined by squamous epithelium. So that is the background in which we can understand adenosis. Now, what is adenosis? It is persistence of the columnar epithelium in the upper one-third of the vagina. Remember that it was there and it was supposed to be replaced by squamous epithelium, but if it persists, we call that adenosis. Now, this can be seen within the population, within the normal population. It's relatively rare, but it can occur. But there is a very high yield association that's much more important to be aware of, and that is that there's an increased incidence of adenosis in females exposed to DES in utero. Now, DES is a drug that's not in use anymore, but it used to be used decades ago for example, for the purposes of threatened abortion, etc. And so this drug, DES, increased the risk of adenosis in women, in the women who were exposed to it in utero. And so that's one very important principle because, again, it ties into embryology. Now, the consequence of that adenosis, and perhaps even just as important as understanding adenosis, is that these women that were exposed to DES in utero, they would get this adenosis, and that adenosis would then increase their risk for a cancer called clear cell adenocarcinoma. And that's a malignant proliferation of glandular epithelium with clear cytoplasm. Now, of course, you recognize that the entire vaginal canal is lined by squamous epithelium, so we shouldn't develop any type of adeno or glandular carcinoma there. However, it occurs in the context of DES-associated vaginal adenosis, so that the patient is exposed to DES, gets the adenosis, now has columnar or glandular cells, and then those glandular cells eventually can become cancer, which would be called clear cell adenocarcinoma. So again, this is high yield because, number one, it gives us a little bit of history, number two, there's a little bit of pharmacology, and number three, it beautifully ties in with embryology. Of course, this drug is no longer in use, and so once these complications were discovered, that led to the cessation of DES usage, and so the drug is no longer in use. The second high-yield discussion that we want to have is about a tumor called embryonal rhabdomyosarcoma. Now, rhabdomyo means skeletal muscle, and sarcoma means malignant mesenchymal tumor. So this is a malignant tumor of skeletal muscle. Again, it generally recapitulates immature skeletal muscle, and it is very rare. I highly doubt you'll ever see a case in practice. However, it's very common on exams, and it's very likely for you to see a picture of this or a classical description of this on an examination. Now, the way this presents is as a grape-like mass protruding from the vagina or the penis. So it's classically in a child less than the age of 5. If it's a female, it usually protrudes from the vagina. If it's a male, it'll be protruding from the penis. And it's a grape-like mass. It's also called sarcoma botrytis, and botrytis means grape-like. Here's a classic picture. This is the mass itself, and you can kind of see how it has these sort of grape-like features to it, these little round nodular areas. Now, the way they like to show it on exams, they actually like to show you a picture of a child with that mass protruding from the vagina. That's the classic picture that shows up on examinations. Remember that this is a rhabdomyosarcoma, and so the malignant cell in rhabdomyosarcoma is called a rhabdomyoblast. And there are two very important things about the rhabdomyoblast that like to show up on exams. Number one, the rhabdomyoblast has cytoplasmic cross-striations. So they could tell you on examination, for example, that the patient has this mass, a biopsy is performed, and immature cells with cytoplasmic cross-striations are seen. What tumor is it? Another way to play the game would be to say that a patient has this mass of biopsies performed and the cells are positive for desmin and myoglobin. Remember that desmin is an intermediate filament that would be present in muscle cells. And so the presence of desmin indicates that you're dealing with a muscle cell. And the myoglobin would indicate that you're dealing with a rhabdomyoblast. So basically, the other way to play the game would be for examiners to say that there's this mass of biopsies performed, the cells are desmin positive and perhaps myoglobin positive. And again, you'd think about embryonal rhabdomyosarcoma. Vaginal carcinoma can also arise, although it's relatively rare. This is a squamous cell carcinoma that would arise from the squamous epithelium of the vaginal mucosa, high-risk HPV. That's the key risk factor. Again, the key ones are 16, 18, and then sometimes 31 and 33, among others. The precursor lesion is called vaginal intraepithelial neoplasia. Remember that high-risk HPV causes dysplasia, which then becomes cancer, and so this would be called VAIN. Vaginal intraepithelial neoplasia. Very important to note for examination purposes that the region of lymph node spread, if the patient gets the tumor and the tumor eventually spreads, the region of lymph node spread is going to depend on where in the vagina it occurs. And that's because the vagina is derived from different things embryologically. For example, you know that the lower two-thirds of the vagina is derived from what? The urogenital sinus, very good. And so, therefore, the tumors from the lower two-thirds of the vagina, they tend to go to the inguinal nodes. Whereas the upper one-third of the vagina is derived from the Müllerian duct, and it tends to go, when that tumor develops and then spreads, it tends to go to the iliac nodes. So this is a nice way by which they can test embryology/anatomy. And so it is important to understand the distinction in regional lymph node spread when we're discussing vaginal carcinoma. And it's a very short section, but it's a relatively high yield section, not uncommon to see questions concerning the things that I've discussed.